Hello, we're now going to talk about the treatment of angina and MIs as part of our cardiac part 2 content. So, coronary artery disease is a leading cause of death in the US, and so it's important that we talk about the treatments of angina and MIs. You will see some overlap of drugs in this presentation that we've already discussed before. The information specifically about angina and MIs is found in chapter 35. So let's review a little bit about angina. The definition is that there's an inadequate oxygen supply to the heart due to narrowing of the coronary arteries. So depending on how narrow the arteries are is what types of symptoms you will see. One of the biggest symptoms is pain, and pain can radiate to the left shoulder and arm. Pain can radiate to the jaw. We know that women exhibit more obscure symptoms of angina, and it's difficult to diagnose in women, and sometimes women don't get proper treatment right away for it because of that difficulty diagnosing. The pain can be a constant type of pain. It can be a crushing sensation to the chest. You can have pallor, dyspnea, diaphoresis, tachycardia, hypertension, and sometimes people report a feeling of impending doom when they are experiencing angina and into possibly an MI. It is usually precipitated by some type of exertion on the heart, whether it be exercise or possibly stress. Not always, though. That's not always the precursor. And so we really have to be careful about taking a health history and getting all the pieces before understanding what's going on with the patients. There are different types of angina. You don't have to memorize these, but I just want you to kind of realize that we have different types of chest pain. So angina can usually be treated without any kind of adverse outcome, and it's relieved by the medications that we're going to discuss here. In the case of unstable angina that occurs at rest, this is a sudden type of pain. This type of angina is what we want to act on immediately. It's a sign of an impending MI, typically due to a total occlusion of the artery. And so our interventions need to be quick and aggressive to prevent further complications, to prevent death even. And so we'll talk about those interventions, but I do want you to realize that there's also vasospastic angina that can happen. And this is just where you have spasms of the coronary arteries. Silent angina is when you have occlusion, but you don't have symptoms quite yet. Stable angina is a pain that is relieved by rest, and it's predictable in frequency. And again, unstable is the one we're really worried about. It's considered an emergency to be treated. Okay, risk factors. So we have to remember that lifestyle behaviors play an important role in increasing the risk of developing angina. We know these behaviors increase risk of coronary artery disease, and so the likelihood will be higher of blockage of arteries from atherosclerosis, plaque buildup. So when you're educating patients, we have to also speak about these behaviors, these risk factors, and ways that they can decrease them. So smoking, high cholesterol, hypertension, diabetes, obesity, physical inactivity. You guys know all these things. Just a quick note about hypertension. It's now defined as a blood pressure above 130/80 per the American Heart Association. So at 130/80, they will start treatment options for patients and begin actively treating that blood pressure. Whereas before they wouldn't treat that blood pressure, they'd wait for it to be a little bit higher. So that's a new change per the American Heart Association. Okay, these are the 3 typical anti-anginal drugs that are used, the 3 classes. The goal with these drugs is to decrease frequency and intensity of episodes, and hoping and return to increase the activity tolerance for those patients. So we have the organic nitrates, which we'll talk about. There's also the beta adrenergic antagonists, the beta blockers, and the calcium channel blockers, the CCBs. The overall goal of anti-anginal medication is to increase oxygen delivery and to decrease oxygen demand on the heart. So we want to increase the oxygen delivery to the coronary arteries so that the heart muscle can be perfused. We also want to decrease the work of the heart so that we're not using up as much oxygen. So how do we decrease the work of the heart? We reduce the heart rate, we reduce the afterload. And the afterload is really, if you think about it, the resistance the heart has to overcome to pump against. Other important things, we want to prevent vasospasms. That's going to help promote dilation, help with perfusion. And we want to reduce the pain the patient is experiencing related to that ischemia. All right, so our first drug class is the organic nitrates. Nitroglycerin is the drug prototype. Nitrostat, Nitrobid are other brand names that you might hear. So nitroglycerin is a very old drug and widely used, and it comes in many forms. There's a sublingual form, there is transdermal, spray, PO, IV, and topical. And so we're going to give this to treat those acute attacks of angina that your patients are experiencing pain with. So what nitroglycerin does is it forms nitric oxide, which causes the release of calcium in the smooth muscle. This will cause arterial and venous dilation, and that vasodilation will allow for more blood to flow through the arteries, which is what we want to increase the oxygen supply to the heart. You could also say that it's going to work by decreasing the amount of blood returning to the heart. So it's actually going to reduce preload, which is going to help the heart to not work as hard and decreases the demand on the heart. Chest pain that doesn't respond to 3 doses of nitroglycerin could indicate an MI is occurring, and sometimes the nitro just can't resolve it. So we typically will give nitro a maximum of 3 times, about a couple of minutes apart or so, and we have to kind of stop at that point because of the side effects of nitro, and then look at some other options instead of continuing to give it. So with the nitroglycerin, the adverse effects are everything related to vasodilation. So flushing of the face, throbbing, kind of headache, feeling, orthostatic hypotension. So that drop, that vasodilation is going to lead to hypotension, and syncope as well is another option. So we wouldn't want to give a patient that is already experiencing hypotension this drug, as well as a patient who is in shock. Somebody who's in shock has a low blood pressure to begin with, so this would further drop the blood pressure. And also somebody with a head injury or head trauma, this is going to potentially cause a further increase in their intracranial pressure with the vasodilation, so you wouldn't want to cause that. Some other drugs that are very similar to nitroglycerin are isosorbide dinitrate and isosorbide mononitrate. You might hear those terms used interchangeably with nitroglycerin. Beta-adrenergic antagonists, we've touched on these so many times now that you guys are set to go. Specifically, atenolol is a drug that we like to use to treat angina. This is selective for beta-1 receptor sites, so it's a selective versus non-selective beta blocker. It's going to decrease the cardiac workload by blocking the receptors in the heart, and by doing so, it's going to help reduce the heart rate and the contractility of the heart, and that is going to help decrease the demand on the heart. So SNS, blockage, we know all about these beta blockers now. Some side effects, going back to our previous stuff, they can cause bradycardia, hypotension. With a hypotension, you can have fatigue, weakness, and dizziness. You don't want to abruptly stop atenolol, especially for somebody who has ischemic heart disease. The angina can be worsened and can actually lead to an MI. So they recommend tapering of this drug versus a hard stop discontinuation. And calcium channel blockers. These are the main drugs that are used to help with angina. Diltiazem, verapamil, and nifedipine. So we know that calcium channel blockers are going to work to reduce oxygen demand on the heart by blocking the calcium channels. This is relaxing that smooth muscle. Okay, it's going to help drop the blood pressure. It's going to help reduce the afterload for the heart. We know that some of the CCBs also are going to impact conduction velocity. We've talked about those drugs. That also is going to reduce the heart rates and work of the heart. The coronary arteries are also affected. They become dilated with calcium channel blockers. That's going to help with perfusion and oxygen delivery to the heart muscle itself. Real quick, back to calcium channel blockers, the adverse effects that you would expect to see: always hypotension, potentially bradycardia, dizziness, those types of symptoms. All right, let's discuss a little bit about myocardial infarction, or MIs, and you'll learn more related to 206 with myocardial infarction as well. So an MI is defined as an ischemia to the heart because of some sort of blockage that is occurring. It's inhibiting the blood from reaching the myocardium. MIs are primarily caused by plaque buildup in the coronary arteries. Chest pain is typically a primary symptom, not necessarily always the case. We know we have other symptoms that can occur, and some people present different symptoms that don't follow what we typically see. Because of the urgency to treat an MI and to remove the clot as quickly as possible, thrombolytics will be used to treat that. So alteplase and streptokinase are two different kinds of thrombolytics. Thrombolytics have a narrow range of safety, but they are great at clot busting. Because of their awesome ability to bust up clots, there are serious adverse effects that can occur throughout the body. The biggest risk is bleeding. Therefore, they are contraindicated in certain situations when patients have a higher risk for bleeding. So it's kind of a risk versus benefit situation. So these thrombolytics are given in the ER. They're given IV under close observation of the patient. And they are effective within 20 minutes of onset to about 12 hours typically afterward. There is more information on the thrombolytic presentation. Aspirin is our next drug that is used to treat MIs. So we will give aspirin if there is a suspected MI occurring. It's an antiplatelet among other actions, so it's going to decrease the platelet formation. It's going to decrease the ability of the thrombi to enlarge. This will help try to get that blood thinned out so further clotting doesn't occur. There is a potential for bleeding with aspirin as well. We especially worry about GI bleeding, but bleeding can occur elsewhere in the body too. It can also cause a lot of stomach irritation, some stomach pains. Ringing in the ears can occur at higher doses of aspirin. So what happens if there's a suspected MI? The patients will be advised to take at home a 325 milligram tablet and chew it up and swallow it ahead of the paramedics coming, the EMS responding. The antiplatelet effects of aspirin occur very quickly. And so it's something that can really help somebody that potentially is having an MI. It can reduce mortality of an MI of up to at least 20%. It can also help with mortality of an MI after the fact, once an MI has occurred. Some patients will take long-term aspirin in lower doses, and you might hear people taking a baby aspirin, 81 milligram baby aspirin, kind of every day to continue those effects. Okay, so other treatments that are used in the treatment of a suspected MI are nitroglycerin, and we talked about nitroglycerin. We give it 3 times for chest pain, for sudden onset of severe chest pain. We give it 5 minutes apart, and this can really help dilate those arteries to help get that blood flow going. But if the pain is not relieved, then we have to move on to bigger drugs such as the thrombolytics. Beta blockers are used because they're going to reduce the demand on the heart. So they are given after an MI to help with the workload of the heart, to reduce the heart rate, the blood pressure, contractility, and that is in turn going to reduce mortality from an MI after the fact. Research has also shown that ACE inhibitors are great to prevent cardiac remodeling. And cardiac remodeling is like cardiac scarring that can occur after an MI. And they can also help suppress dysrhythmias from occurring. Many times patients will end up on lifelong therapy with ACE inhibitors after they've experienced an MI. And pain medicine is also kind of an important thing in treatments of MIs because a patient will experience significant pain and they will many times be given morphine sulfates in the acute stages of an MI. And so we want to help reduce the stress and that pain that they are experiencing from the ischemia that's occurring. So that's another important piece that we have to address with our patients. And you'll learn about some of these other things when you discuss MIs in 206. Thanks for listening.